Hello, my name is Rajanikanth Rajagopal. Before I start my talk, I would like to thank Dr. Khanna and the organizers for inviting me to be a part of this meeting. It's always a pleasure to be a part of APVIC, be it in person in beautiful Delhi or online, as it's been last year and this year. My topic today is AV fistula intervention. What's new from the cardiologists? So I'm an interventional cardiologist. I work in a clinical JPMC cardiac center in Pune. I specialize in complex coronary intervention with an interest in imaging and physiology. I first developed interest in AV fistula intervention about 5 years ago. I was visiting this hospital in Korea with my vascular surgeon colleague who sat there in the middle with me. We worked with these two interventional radiologists who were doing a wide variety of peripheral interventions, including fistula intervention. They had an excellent service where they fixed fistulas the same day from the dialysis center and sent them back so that they could resume their dialysis without needing any perm cath or any delays in their treatments. So we learned a lot from them, and we came back and set up a service in Brunei. It's been well established now for a few years, and we've done a few hundred interventions. What I've learned over the last few years is there are several skills and knowledge which, as a cardiologist, we are able to transfer to the field of fistula intervention. And today I would like to talk about one of them, the distal trans-radial axis for AV fistula intervention. Now, traditionally, when we try to do fistula intervention, we have a few access options. We could go in from the cephalic vein, going antegradally, up into the cephalic veins and the central veins. We could use the cephalic vein in a retrograde fashion, and that allows us access to the juxtaanastomotic region as well as into the artery. We can also go in from the radial artery, and this gives us access to both the arterial and the venous limbs of the fistula, and we can reach all the way to the central veins with this access. As an interventional cardiologist, this is my normal access of choice whenever the radial artery is available. Now, the distal trans-radial axis was made popular in about 2017 by Dr. Kemeny from Amsterdam, who recorded his experience and published this article. He explained the technique of the left distal trans-radial axis, explained the advantages of the procedures, and he also predicted development in the technique. Now, in the distal trans-radial axis, we access the artery in the anatomical snuff box, which you can see on the top right picture, and that's it. You can see the comparison of the anatomy on the left side. So when you put a sheath in the anatomical snuff box, the tip ends up somewhere near where your normal puncture would be, and that is usually the area where you tend to have the anastomosis of a radiocephalic fistula. There are several advantages of using the distal trans-radial axis. It is a comfortable arm position for the patient because they don't have to keep their arm up with the palm facing up. If you're doing intervention from the left distal trans-radial axis, the operator can still work from the right side without having to bend over. This is not much of an issue with fistula intervention because we will just stay on the other side. There is a low rate of radial artery occlusion. There is lower risk of bleeding because we have easy hemostasis. You have the option of saving the radial artery for potential future grafting. And in fact, the distal trans-radial axis can be used to recanalize a radial artery that's been occluded from a previous procedure. Thanks to all this, there has been good uptake of this technique, not just in cardiology, but also in other fields such as interventional neuroradiology. This table shows you different publications where they have used distal trans-radial axis for cerebral angiography and intervention. Now, today I would like to talk about a couple of cases where we used distal trans-radial axis for fistula intervention. These are fairly straightforward cases technically, and the focus really is on how we use the distal trans-radial axis. So one of my favorite songs, The Thrill Is Gone by B.B. King, always a good reference to fistula intervention. Right, So our first patient was a 39-year-old lady who's been on dialysis for about 6 years. History of hypertension, asthma, and TB in the past. She had a right radiocephalic fistula for about 3 years. Recently, she had poor blood flow and it was occluded, and she had no thrill for about 3 days. Examination showed just abscess of thrill but no swelling or erythema. We did an ultrasound that showed that there were 2 areas in the venous limb filled with clot with narrowed segments in between. So this is a picture of the patient's fistula. The arrow points at the anastomosis of the radiocephalic fistula. You can see it's pretty close to the rest, and therefore a normal radial artery access would not be possible here. Since we decided to go for a distal transradial on the right hand as it was. So we gave sedation as we normally do with midazolam 1 milligram. We injected local anesthetic, and then we used a 5 French pediatric 10 millimeter sheet. It's important to point out that when using the distal transradial access, we need to use open needles and not the closed needles which go through and through. So with an open needle, we got access and put in this short pediatric sheet. We then took a BER2 catheter along with Terumo 035 wire and made our way up. So the first picture is from the sheath, and you can see that it's filling the artery, and from there we were able to use the Terumo wire or the BER2 catheter to manipulate our way into the fistula. And you see the first picture on the right side where there are 2 aneurysmal segments with a lot of thrombus in them, and the venous limb is very narrowed. We then proceeded to intervene. So using the BER catheter, we were able to maneuver the Terumo 034 wire followed by the BER2 catheter. We then started our angioplasty. We did balloon dilatation with a Mustang 4x40 mm balloon. We saw better flow after that, but there's a lot of thrombus. We then inserted a Craig McNamara infusion catheter. We injected 2 lots of TPA into the venous limb, and that improved the flow, and some of the thrombus was resolved. So that is us checking the position of the Craig McNamara catheter. We did further dilatation with a 5 millimeter balloon, and the venous limb looked a lot better, and that was the final result. So at the end of the procedure, we had an excellent thrill back in the fistula. The sheath was removed. We deployed a compression device. We find the Nichiban Skep-T to be the most suitable device in this situation rather than a TR band. Patient was commenced at hemodialysis the next day. This is a picture of the same patient having dialysis subsequently. We did 9 months follow-up on the patient just clinically, and just measurements, and the patient had good flow in the fistula and had no issues. So the key points from this case is the fact that we used the left distal radial access. A single puncture got us access into the artery and the vein. We were able to do successful angioplasty as well as thrombolysis, and we got easy hemostasis. The next patient was a 62-year-old man with a left radiocephalic fistula created about a year ago. He had poor flow for a few weeks. That's a picture of at the beginning of the procedure, where we placed once again a short 6 French sheath into the distal radial artery, and our very first picture showed severe stenosis in the juxtamotic region. We passed a 035 Terumo wire. We dilated with a 3 millimeter balloon, and then with a 5 millimeter balloon, you can see a bit of wasting there. So we completed the angiograms first by passing the BER2 catheter. We did our completion angiograms and came back to complete the angioplasty. We exchanged the 035 for a 018 wire. We tried a 5 millimeter scoring balloon, which didn't really work. Then we swapped for a 5 millimeter cutting balloon. The picture in the middle is an angiogram through the sheath to confirm the position of the cutting balloon to make sure it's not in the artery. Then we inflated the cutting balloon, which and the constriction finally gave way, and we got good expansion. And we had a good final result. We secured hemostasis using a Nichiban Skep-T device, and we were able to resume dialysis the next day. The points are again very similar. The use of the left radial axis in this occasion, single puncture, we are able to use 035 and the 018 system, including a cutting balloon to get a good final result. So that's our experience, and we've done maybe a handful of procedures in between then and now. To be honest, there's a team of us, that's me and the vascular surgeon. The vascular surgeon still prefers to use the cephalic vein approach. If I do the brachial cephalic fistulas, I tend to go from the radial artery. But if I'm treating a radiocephalic fistula, I do try the distal radial axis, which makes, and if you get through, it makes the procedure quite simple and elegant. So while looking through the literature before this talk, I found this article from the US, so where they had reported their experience with the snuff box distal radial artery axis. They compared this with direct fistula axis. They used ultrasound guidance for all their punctures, and I think that is a good idea. They only used hand pressure for hemostasis. I'm not sure if that's a good idea. They used it in about 17 out of the 68 patients with radiocephalic fistula, a quarter of them, and all of them are successful. They found that the main procedure types are similar, and they had minor hematoma in about 12%, which is compared to just 2% of the direct fistula axis. I do wonder if compression device would have been better. There were no major complications though. I think that's quite useful, showing the feasibility of this axis for fistula intervention. So to conclude, distal transradial axis is well established now in coronary intervention, and it could be an option for treating AV fistulas, especially radiocephalic fistula. A single puncture could give access to the artery and the vein. It is suitable for treatment of fistula and central veins, including adjunctive techniques, as long as they all fit into a 6-vein sheath. Hemostasis is easy, and there is a low risk of complications.
Thank you, Rajni. That was great. And I do remember the times when I came to your hospital to do some cases, and you've been to our meeting many times.